it's pretty wild to think about in 2008, there really weren't any FDA-approved therapies for metastatic hepatocellular carcinoma. And then all of a sudden we had sorafenib, right? And then for many years we had sorafenib. And now there's been, I think, a virtual explosion, right, of drugs that we now use to treat metastatic hepatocellular carcinoma. But of course, one of the major advances have been this institution or implementation of immunotherapy for our patients with metastatic hepatocellular carcinoma. And so, Nina, just really wanted to ask you about really, how immunotherapy has really changed the landscape for the treatment of metastatic hepatocellular carcinoma, and how you think about implementing immunotherapy for HCC.
Yeah, I think as you mentioned, I remember how it was sorafenib. That's it, sorafenib, and that's all we would do and offer to our patients. And it was very hard and difficult to treat our patients because it's a common problem. I work in an area where HCC is actually one of the most highest prevalent area in Philadelphia. So it's something that we used to see very often. But now we have all these different options. And you say when you have a lot of options, the question next becomes what's the best and what's next? And we can talk about that too. But in general, I think it all started, first we got the data of single agent PD-1 inhibitors, nivolumab, Pembro didn't work, but nivolumab had some initial positive data. Unfortunately, we were using it right especially for the the B7 or the Child-Pugh, like the little shaky patients. We started using it very enthusiastically, I would say, like at least we have an option for them. But then 2021, they withdrew the second line indication for nivolumab and I just saw like an updated analysis for the 5-year OS for the nivolumab came out, and it is interesting how like the whole story ping pong between yes it's effective, yes it's not, but then fortunately we ended up getting the data for combination options. So the atezobev or the combination of atezolizumab and bevacizumab using the IMbrave study was basically like I think a game changer for these patients and for our patients, right? I as a medical oncologist started seeing patients early on, right? I remember like previously we would only see patients that were metastatic, like where no further local treatments could be offered. And now I was seeing patients who were, locally advanced, like a lot of localized disease or rapidly progressing disease that still was, limited to the liver. So more healthier patients coming to us with the availability of these new options. So, the combination of atezobev has sort of become my go-to treatment for all my patients. It's, amazing long-term overall survival, more than 19, 20 months. That's really cool. More recent, the kid on the block, as we call it, is the durvalumab plus tremelimumab, the STRIDE regimen, which I have, I have to admit, I haven't used as much as I've done the atezo-bev combination. It's just because probably it's newer and, we already had something that was available in that area. So I haven't used it as much, but I have, and I like really at this point have quite a few patients, and it's a very good regimen too, right? Every 4 weeks you get treated, and it's really, really like the way it has changed the treatment for HCC is really remarkable. These are effective treatments, and or average, like the survival for the durva-tremi was like 16, 17 months, and it's like all like really way better than what we had seen before.
Yeah, I completely agree, and I think that combination of atezolizumab and bevacizumab really did change the landscape, certainly in a frontline setting, but just in general, right? The use of immunotherapy for HCC in a situation where, sometimes some of the tyrosine kinase inhibitors can be difficult to tolerate, as we well know. You have brought up this idea of atezo-bev and then now durva-trem, right? The new kid on the block. And, I would love to hear, and I think people would love to hear how you think about choosing one regimen versus the other, or if there's a certain population that, you would recommend atezo-bev more, or maybe just durva-trem more.
Yeah, so I think if you look at and as a purist, if you're just looking at the trial population for both these studies, they were very similar, right? They were patient, except some like bevacizumab contraindications that we can talk about in detail, but the disease specific, inclusions were similar. They were patients had preserved liver function, did not have portal vein thromboses, like all the cherry-picked patients that go on a clinical trial in general. So it's that I don't think helps us differentiate as much, like, hey, is one better for patients with higher burden versus less burden? I don't think that is an answer, but obviously, we know the atezo-bev combination excluded patients who had bev-associated contraindications, and that's sort of where I land all my like decision of one versus the other right now. Even though like previously when we didn't have the durva-tremi combination, I would do an EGD on every patient before starting to make sure they don't have varices. But I think at this point, they can develop varices during the treatment when they have advanced cirrhosis. So if my patient has advanced cirrhosis with evidence of varices or history of varices ever in the past two, I tend to shy away from bevacizumab because I have an alternative. But if I have a patient, so I would probably say my knee-jerk reaction is atezo-bev just because it's been there longer, no other reason for that. But if they have any contraindication for bevacizumab, I tend to go towards durva-tremi. I also have patients who rather like the every 4-week treatment than every 3-week treatment. So if they're coming from far away, that's an important consideration for some of them. So those are my two reasons. If you tell me is one better than the other, if you know the answer, I would gladly accept that as my choice.
No, for sure. And exactly. I mean, we would love to see that head-to-head study. I don't think we'll really get it, but it does represent two really wonderful options. And I completely wholeheartedly agree. In patients really that are not bevacizumab eligible, it's really, really nice to be able to offer something, still in the immunotherapy space, and durva-trem would obviously be there.
I have a question for you though.
Oh yeah, please.
A lot of my patients, and actually, like, think about that. We have like classes of drugs like immunotherapy, then VEGF targeted therapies, right? These are the two big classes of drugs we have. What are your takes on the idea that if you only do like durva-tremi from the frontline setting, that leaves an option that the patient has never seen a TKI for the second line. Whereas if you just do atezo-bev in the frontline, then you've seen a VEGF targeted agent and immunotherapy, then what do you do in the second line? It's much easier if you do durva-tremi first, you know what you're going to do second line, but not as much if you do atezo-bev. So I was wondering if that, like, I've thought about it, but I've actually never like acted upon it in that way, like thinking that way.
Yeah, I think it's a really great question. And obviously the answer is we really don't know. And unfortunately, a lot of the second line and beyond drugs that we have in hepatocellular carcinoma are really kind of compared to essentially placebo, right? Because at the time that the trials were done, there really wasn't a second line option for hepatocellular carcinoma. We'll definitely touch on this as we get to a question about how we think about sequencing. And, I think that's an interesting idea, right? If you've already attacked VEGF, then what could be potentially the impact of a drug like a cabozantinib, certainly, or lenvatinib. Ramucirumab is a drug that's very, very similar to bevacizumab, and that is like the one drug that I probably would not give, right? If we've given prior bevacizumab, I'm not sure ramucirumab is a drug of choice, really kind of in a second-line setting. But we also know that the tyrosine kinase inhibitors like a lenvatinib or regorafenib or cabozantinib, those drugs can oftentimes hit a lot more targets, right, than what we normally think about with just a monoclonal antibody like ramucirumab or bevacizumab. So I still think that there are probably some growth factor inhibition pathways that are being inhibited by the TKIs that are just a little bit different. But it is a wonderful question and one that we would love more investigation into.